So I will start my talk. I run the preterm labor surveillance clinic at Salimu Gabe, which is one of the central hospitals in Harare. So my talk would be on innovations that we've implemented in the preterm labor clinic that we have. Right, so the outline of my talk, I'll give a brief introduction of what preterm labor is and the Zimbabwean situation, prevention mechanisms, the protocol that we employ, and also the common pitfalls that you encounter in using ultrasound in monitoring those who are at risk of having a preterm. So globally, about 130 million babies are born, of which 4 million of those will die in the first 4 weeks of life. And prematurity has been the major direct cause of that. So in the Zimbabwean situation, as of 2013, prematurity led to 33% of neonatal deaths, which is quite significant. So despite the increased knowledge and risk factors and mechanisms of preterm labor, there's still a challenge in reducing the rates of preterm labor, and this can be attributed to one, absence of an effective screening test which will identify those that are at risk of having preterm labor, and also lack of an effective intervention which will prevent this complication. So in terms of screening test, as I will describe later in the talk, to say we have transabdominal and transvaginal routes of assessing the cervix, but in the majority of instances, it's the transabdominal approach which is used, and it also comes with its shortcomings, as you see in the future slides. So preterm labor contributes 34% of perinatal mortality globally, and transvaginal ultrasound now is readily available in some institutions. And through the use of this tool, we can be able to measure the cervix and identify those women who are at risk of preterm delivery. So in our clinic, we see those who may be late bookers, and maybe they book at the 20 to 22 week scan, which is the anomaly scan. And when they have their usual routine assessment, then they are identified to have short cervix. So they also join our clinic. But the majority of the patients that we see, so my title was From History to Hope. So those who have got a history of several pregnancy losses are the ones that we monitor and give hope until we discharge them from the clinic at 28 weeks. So it's common practice that a cervical stitch is inserted in Zimbabwe so as to increase the gestation before any complications of preterm can be in play. So since the inception of the fetal medicine unit and the preterm surveillance clinic in 2019, we've seen a significant number of women who have got a previous history of preterm delivery. So preterm delivery would be that instant whereby someone delivers before 37 weeks of gestation. So it can be spontaneous. And we've also seen patients who would have their anomaly scan, and then as that happens, then they are seen to have a short cervix. Then those who are indicated to have a cervical stitch because of their history, we see them soon after their 11 to 13 week scan, when they have been cleared not to have any congenital anomalies, any major structural defects. So those ones are the ones who will have their cervical stitch inserted between 13 to about 20 weeks, thereabout. So they're the ones whom we follow up. So this is just data that we got outcomes on from our database. So out of about 707, about pretty much of those whom we've seen, about 80% of them, they delivered after 31 weeks, but still the the number of those that are still less than 37 weeks, the percentage is still greater than 50%, which we want to reduce so that we move these ones, these 20%, want to move them to at least above 31 weeks, so that at least if they can have at least 1,000 grams and all, then their survival rates will also increase as previously discussed. So the following are the ones that are at an increased risk of spontaneous preterm birth. And to us, they are supposed to be offered an appointment in the preterm surveillance clinic. So we see an average of 20 patients a week. And these are the ones that will be following up: those who've had a history of spontaneous preterm birth, those with PROM, those that have got a history of a sacrilege of progesterone use in their previous pregnancy, even if their pregnancy got to term, and those who would have a sacrilege in situ, and those with congenital uterine anomalies. So now, the model that we use would now combine the obstetric history of those groups that I've just described, and also the cervical length. So when we get this information, this will now provide a better prediction of the risk of developing preterm delivery. So this will hence improve the sensitivity of the screening that we'll be performing. So this is just epidemiology to say cervical sacrilege will reduce the risk of preterm birth before 34 weeks by 25%. So some may have an elective that will be done soon after the 11 to 13 week scan. And if it demonstrates that there are no major fetal abnormalities, then they join our clinic. Then we'll continuously see them every 2 weeks. So we'll just be checking their cervical length. Whenever it becomes less than 25 millimeters, that's when the protocol will point towards them getting a prescription of progesterone, which they'll be using from 20 to 34 weeks. So vaginal progesterone itself will reduce the rate of preterm labor by 35 to 40%. So these are the references. You may have a look at them. And also now the protocol itself. So at first, the patient will need to empty a bladder. So whenever you're performing a transvaginal scan, it's always better to ask them to empty their bladder, as you see the pitfalls in the later slides. So a transvaginal probe will be inserted in the vagina, and then it will be directed towards the anterior fornix, and sagittal views of the cervix will be obtained. And the one that will require for measurement is the one that shows the endocervical canal. Also, you should be able to see the internal os and the external os. You see images in a moment. And electronic calipers will be used to measure the linear distance between the triangular area that you see at the external os and a sort of V-shaped notch at the internal os. So for those who have a stitch inserted, we'll also determine the pre-stitch and post-stitch lengths. So we are also guided by the most recent ESOP guideline, which was released, I think, last year, June, July, thereabout. So you can also have a look at that one, ESOP guideline for preterm labor, etc., 2022. So for the pre-stitch and post-stitch, so the pre-stitch, we need the stitch to be as close as possible to the internal os, as you see in the coming images. And as we also check the cervical lengths and also stitch positions, we'll also be assessing the viability and placentation to say, of course, the cervix is long enough, of course, the stitch is at the correct location, but we also need to know if the fetus is viable. So we also perform a heart rate assessment, fluid, and also placentation. So the exam itself should last at least more than 3 minutes. Why? Because in 1% of the cases, the cervix length tends to change because of uterine contractions that will be occurring at that time. So in such instances, the shortest possible measurement that you get is the one that you need to record. And since because of culture, etc., and acceptability of transvaginal scan, consent is very important. So in our setup, consent, we always ask consent from the patients, and we also inform them to say your data may be used for research. They may offer it verbal, or if verbal is not enough for some cases, we may need also to have the written consent. Then always, even if you are female, just ensure that there's a chaperone to avoid litigation issues. And also, as for infection control, so we always cover the probe with a sheath, and we apply gel inside the sheath and also outside the sheath. So from my knowledge, we haven't had any instances of infection that were reported following this practice from patients from our clinic. Then for bias control, so before the one will be scanning, before they do their measurement, they are blinded to the previous length of the cervix. So if you are told of a certain measurement that was recorded in the previous scan, it also tends to give you a bit of bias. So it's always recommended to just first scan, give your measurement, then later on try to check the previous measurement that was gotten. These are just images showing normal cervixes. So where the pointer is, this will be the amniotic cavity. Then this will be the internal os. Then the external os would be up here. As also shown in this image, this will be our internal os and our external os over here. So we need to see this vaginal canal. Need to see it in its entirety. And when it comes to the measurements, so in those cervixes that are long, as you find in this image to say, you may take the shortest possible distance. If you are to compare, this was one patient. If you are to compare, this one gave us 38 millimeters, where we took the shortest possible distance. So if the shortest possible distance is greater than 25, even if you trace into the cervix canal, you find this one was 48, so it will still be a long cervix. So that's just technique. Then when it comes to transabdominal, so the transabdominal will fail to visualize the cervix in the majority of cases, particularly those with short cervix, because whenever people perform the transabdominal, they ask patients to drink water, and that may distend the bladder. As the bladder is distended, that will now falsely elongate the cervix. So you won't get a true appreciation of the cervix. That's number one. Then the other thing would be to give you a false placenta previa because of the effect of the bladder on the cervix. Then there's also the transperineal route, where you place a curvilinear probe sagittally between the labia. So these are just transabdominal images, but because of those shortfalls, the bladder may be too full, may be too empty, then the cervix may be obscured, or there'll be false elongation and false positive placental previa. So transabdominal, its sensitivity and specificity is very much reduced compared to the transvaginal route. Then this is just an image showing a short cervix with evidence of funneling. So again, these are the kind of patients that we follow up. And again, coming to the title, From History to Hope. So you hear histories of someone who would be on their 10th pregnancy with 9 pregnancy losses. So whenever we see these kind of short cervix, that's when we recommend them to commence progesterone. Then we'll continuously follow them up. So in the cases that we've seen, you actually see the effect of progesterone. If you see them too weakly, or in those who might have severe shortening of the cervix, whom we may see weekly, you also see the cervix actually changing, and the funneling also tends to resolve. Then these images are just showing an open cervix with bulging membranes. So again, it's very critical that at the anomaly scan, you make an effort to assess the cervix transvaginally, especially. Because most of the patients that we see who have open cervix and bulging membranes, they would have had an anomaly scan somewhere, and the one that would have performed the scan now fails to perform a transvaginal scan to pick such instances of cervical shortening and also cervical incompetencies. So the next image just shows us a failed stitch. So these are the cervical stitch, then the nodes of the stitch that will be, one is misplaced, the one in the anterior one will be misplaced, just like here. So again, we also check those who have their stitch inserted, then we see them 2 weeks post insertion, so that we also confirm the location of the stitch. Then these images just showing a normal cervix with a stitch that is correctly placed. So this was just one patient. Then common pitfalls, you need to be mindful. Even if you are performing a transvaginal scan, you need to ask your patient to empty their blood. So you need them to empty everything out. Again, a full bladder will falsely elongate the cervix. So you also need to make sure you don't put too much pressure on the anterior cervix as shown in this image. So you need to see the anterior and the posterior cervix. They should also all be of similar diameters, just like shown in these images. So you should also make sure that you measure and also see that they are approximately of equal thickness, the anterior and the posterior cervix. Right, so acknowledgement. I need to acknowledge the FMF Zim team for a great work they're doing. So the other clinics will also be feeding into our clinic, will also be feeding into their clinic. So what happens is, if we are following up someone with a short cervix, when they reach their 20 to 22 gestation, we also recommend them to go to the anomaly clinic. They have their anomaly scan, then they return for follow-up. Then we follow those patients up until 28 weeks. At 28 weeks, we also perform the usual growth and Doppler assessment. If we notice that there are issues with their Dopplers, we also now point them to the placental disorders clinic. So with these words, here ends my